Hello, everyone. Good evening. I hope everybody can hear me okay. Welcome to the first ever virtual clinicopathologic conference hosted by the Philadelphia Rheumatism Society. I'm Shraddha Jatwani, faculty and associate program director at Albert Einstein Medical Center, Philadelphia. I have been given this esteemed opportunity to chair the CPC conference for the Philadelphia Rheumatism Society this year. It's a very different age and world this year. All of us new rheumatologists were very excited to meet all of our peers and colleagues here in Philadelphia area in person. Well, the Philadelphia Rheumatism Society has given us a chance to do this virtually. And while we are here, I would like to thank all our pharmaceutical sponsors who have helped with us with this conference. Um, I'll name the sponsors: AbbVie, Amgen, Aurinia, GlaxoSmithKline, Janssen, Mallinckrodt, Novartis, Sanofi, Genzyme. Just to give a brief introduction about today's CPC, we will be discussing two cases. The case presenter will present the case without giving away the diagnosis for about 8 minutes. Then we will have one of our discussants discuss the potential workup and possible diagnosis for about 10 minutes. We will move on to the presenter again for final diagnosis and a brief discussion for about 10 minutes. Audience can keep writing questions in the Q&A section on the screens, and I will pose the audience questions and comments at appropriate intervals and at the end of the presentation if we have time. I'm going to give a few more minutes so that more participants can join, and then I'll introduce our presenters for the first case. Welcome to those who have just joined. We will be starting with our first case today. I would like to introduce our speakers for the first case. It will be presented by Dr. Amara Hussain, our second year rheumatology fellow at Hospital of University of Pennsylvania. And our discussant for the first case will be Dr. Jennifer Gao. She is currently a faculty member at Temple University Rheumatology Division. She completed her residency at Mount Sinai Beth Israel, New York, and rheumatology fellowship at Emory University, Atlanta, before she moved to Temple in July 2020. Let's welcome Dr. Hussain.
Thank you, Dr. Jatwani, for the introduction. And can my slides be shared, please? Okay, next slide. So my name is Amara Hussain, and I'm presenting a case today. The patient presented with primary complaint of fevers and lethargy. Next slide. This is a 62-year-old female with past medical history of osteopenia, left hip fracture, status post left hip replacement, uterine fibroids, status post subtotal hysterectomy, who presented as an outside hospital transfer for further workup and rheumatologic evaluation for chronic complaints of muscle weakness, ptosis, hoarseness, and dysphagia, with new complaints of fevers, headaches, leg pain, malaise, and skin rash. 1 year back, patient developed bilateral thumb weakness, having difficulty lifting things, followed by eyelid weakness with difficulty opening eyes only in the morning, associated with some difficulty swallowing liquids and hoarseness of voice. She was evaluated by neurology 3 months prior. Workup was negative for anti-musk antibodies, striated muscle antibodies, VGCC antibodies, anti-Jovan antibodies, also negative for ANA-RF done at an outside setting. Normal SPEP, immunofixation, CK was within normal limits. EMG was planned. 2 weeks prior to her presentation at the hospital, she developed malaise, fatigue, headaches, pain around her left eye, fevers, followed by worsening muscle weakness and severe pain in calves and left leg to the point she was unable to walk. 10 days later, she developed skin rash over her chest and back and erythema on her face. Hence, she presented to the ER. Next slide. At the outside hospital, she had persistent fevers as high as 103.3 with some mild tachycardia. She was started on broad spectrum antibiotics. Her LP was unremarkable. So was infectious workup. Antibiotics were stopped, and the decision was made to transfer her to our facility for a more thorough autoimmune workup. Review of system was positive for fatigue, leg pain, skin rash, headache, orbital pain, fevers, thumb weakness, dysphagia. Negative for Raynaud's, muscle weakness, oral nasal ulcers, recurrent URI, hair loss, Zika symptoms, vision changes, jaw claudication, and diplopia. Her past medical history was positive for uterine fibroids and osteopenia. Social history: she is a non smoker, occasionally drinks alcohol, no substance abuse. Family history was positive, with father having CAD, sister has vitiligo. She was only using estradiol patch every day. Surgical history was positive for subtotal hysterectomy for her left hip and left hip replacement. Allergies, none. Next slide. Physical examination, I'll focus on the positive findings. She appeared well. The findings which were positive in her case were raised maculopapular rash on chest and some patches on back, no rashes on thighs, MCPs, eyelids, and face. Neuro examination, she was alert, awake, oriented times 3. Her sensory, there were no sensory findings. However, her strength was 4 plus 5 on bilateral triceps. Bilateral thigh extensors were 4 positive on 5. Hip extensors and flexors were 5.5. Her examination was variable and mostly restricted by pain. Musculoskeletal, she had tenderness of bilateral CMC joints, but they were not swollen. Atrophy of the thenar eminence was also noted. All other joints were non-tender, no swelling, warmth, or erythema noted. Bilateral shins were tender to touch, calves were non-tender. Next slide. Her labs, her WBCs was 4.4 to 6.6. Hemoglobin was 9.5. Her platelets were 252. Her CRP was 29. Her ESR was 73. Her ALP was elevated at 331. Elevated GGT, AST, ALT were within normal limits. Albumin was low, 2.7. Creatinine 0.5. LDH and heptoglobulins were within normal limits. Her ferritin was 600. CK was within normal limits. Her immunoglobulins were within normal limits. RF, ANA, ANCA, asthma, anti-dsDNA, SSA, SSB were negative, and complements were within normal limits. Anti-MuSK antibodies, acetylcholine receptor antibodies, Jo1 were negative. UA was unremarkable. SPAP immunofixation was negative. Her TSH was within normal limits. Folate, B12 were within normal limits. Her iron level was low, 14. Iron binding was capacity was 151, which was low, and saturation was low. Next slide. Her blood cultures were negative. Blood parasites were negative. Hepatitis serologies were negative. Urine cultures were negative. DAT screen was negative. Lyme negative. Babesia was negative. She was also negative on various parasitic evaluation. She underwent CT abdomen pelvis with IV contrast, which showed which was negative for any abnormalities. Next, her CT chest with IV contrast showed with probable nodular pleural parenchymal scarring at right lung apex, which was thought to be of unknown significance, and a follow-up imaging in 6 months was required. Next, her EMG was also done of the right lower extremity and right upper extremity, which was within normal limits. No peripheral neuropathy or muscular neuropathy noted. At this point, I will ask for any questions, differentials, and the other participants.
So the audience can ask questions in the Q&A box if they have any. So Amara, one question is TB testing.
I am not sure about that. Yeah.
Okay. Next question is, what were the chronic symptoms versus the more acute symptoms?
The chronic symptoms were her ptosis, problems with opening her eyelids only for a couple of minutes in the morning, and the more acute symptoms were headaches, new onset skin rash over her chest, fevers, fatigue, and malaise.
TB test was not available, I understand, as one other.
I think it was. I'm not sure. Yeah.
Okay. I don't see any other questions in the chat box. We'll give one more minute before we give it to Dr. Gao. So another question popped up, aquaporin 4 antibody.
This was not done. This was not done.
What kind of work did she do? Any chemical exposure?
No chemical exposure, mostly like a desk job.
Okay, so now we have Dr. Gao.
All righty. Hi, everyone. Good evening. My name's Jennifer Gao, as mentioned. Thank you all for joining us this evening, and thank you to the Philadelphia Rheumatism Society and today's organizers for inviting me to participate in today's CPC. Most importantly, thank you to Dr. Jatwani for moderating this session, as well as to Dr. Hussain for presenting this interesting case. So, like your questions, I wanted to break it down in terms of what was acute and what was chronic. And whenever I'm given a case, I always want to try to break it down in 1 to 2 sentences for easier digestion. So in summary, we have a 62-year-old female with a history of osteopenia, status post left hip fracture, status post replacement due to trauma, who comes in for evaluation of a failure to thrive picture associated with myalgia and malaise. Her pertinent positives include more than 1 year duration of bilateral thumb weakness and ophthalmoplegia, which was most prominent to me, as well as dysphagia and hoarseness, and a relatively acute onset of less than 2 weeks of increasing pain to her legs, particularly the left leg, as well as fevers, rash on the chest, back, and face. Her past negative workup includes a negative anti-muscle specific kinase, negative striated muscle antibody, negative calcium channel antibody, JOL1, RFANA, and most importantly, her CK was not elevated. Her inpatient exam was remarkable for a macular-papular rash on her chest and neck, variable strength across her muscle groups. Predominantly, it appeared that her extensors were tested. And then she also had a thenar eminence atrophy. Inpatient workup was remarkable for an elevated sedimentation rate, an elevated CRP, an elevated ALP phos of 331. We don't know if the source is hepatobiliary or bone. She also has what I presume is new onset anemia or relatively subacute, given the hemoglobin of 9, with an elevated ferritin and a low iron, all in all suggestive of some type of anemia of chronic disease. Her infectious workup to date has been negative. The EMG of her right upper extremity and right lower extremity, which interestingly to me appears to be contralateral to the initial site of her pain and weakness, which she cited as the left leg, was normal. And her CT imaging of the abdomen, pelvis, and chest was largely unremarkable, certainly no mentioning of any vasculature derangement. But there was some probable scarring of the right apical lung, which we are uncertain of its etiology. Can we move to the next slide? Great. So when I'm thinking of this picture, I'm thinking of a woman with an elevated ferritin and anemia and a low albumin state, which generally implies a relatively chronic pro-inflammatory state. Her primary concern was this ongoing weakness, along with a normal CK and a normal EMG of the contralateral side of weakness and pain. So recall she came in complaining of left-sided weakness, but she did have a hip fracture / replacement there. However, the EMG was done on the right side. So whenever I'm thinking of a differential, I like to attack it in terms of a systemic approach, going from head to toe. Neurology, certainly spinal muscular atrophy, mitochondrial disease might come up. It's a little bit unusual given her age. One typically anticipates an earlier age of onset, but unusual things can happen in medicine, especially if a patient is a carrier with varying phenotypic penetration. Endocrine is pretty high up there too. Thyroid dysfunction, especially hypothyroid, is something to consider with the ophthalmoplegia. Thenar atrophy can also be seen in thyroid dysfunction. We know that her TSH was normal, but we don't have information regarding her free T4 as well as her TPO status, which can imply a more subclinical course, as there are case series showing Hashimoto thyroiditis with normal TSH. Adrenal insufficiency or dysfunction can also be considered, but this patient didn't endorse any GI dysfunction, and her blood pressure was relatively normal. Going down the list, hemonc, paraneoplastic phenomenon is certainly within the realms of consideration, as well as amyloidosis. But her CPAP and UA was normal, and her CT abdomen pelvis was unremarkable. In terms of GI, I know someone mentioned what was her job. Vitamin B1 and E is something to consider, especially in terms of deficiency. B1 is linked to beriberi, but one anticipates more neurological features. There has been isolated case reports in the 1970s of vitamin E deficiency linked to ophthalmoplegia with weakness. Heavy metal poisoning can also be considered, but I'm assuming that the patient lives in the US. She doesn't drink any well water that we know of. Infectious etiology certainly is something to consider, especially with the TB status that is indeterminate. We know that tuberculosis, syphilis can all be mimickers of rheumatological disease, especially in the context of this right apical scarring that we don't know the etiology of. And then last but not least, in terms of rheumatologic, which applies to us, given the leading HPI, I was considering more of an inflammatory myopathy, especially given her profound state of weakness, as well as the failure to thrive picture. Within this, certainly inclusion body myopathy was something to be considered, along with dermatomyositis, especially in the context of a thenar group atrophy. and the suspected B sign slash Shaw sign. That said, other differentials to also consider, but perhaps lower down in the list for me, was a vasculopathy. Typically with this, we tend to anticipate a more profound state of decline, especially given the fact that her symptoms have progressed for over a year and it's been untreated. Moreover, CAT scans of her chest as well as abdomen and pelvis didn't show any large vessel derangement that one typically anticipates in GCA, or even a medium vessel vasculopathy that one sees in PAN. Other differentials to also consider is if this could truly be a frank connective tissue disease such as lupus or scleroderma, especially with some overlap of dermatomyositis, but her age of onset is rather unusual. Can we go to the next slide? So what workup would I have liked? I think neurology input would have been great, especially if we wanted to discern any type of mitochondrial disease. An EMG of the left leg might also be helpful, especially since that was the presenting site of weakness, whereas the test that was done was on the right side. And certainly if there was any abnormalities in the EMG, it would prompt me to get an MRI of the pelvis to look for any type of muscle edema, and that in turn might prompt me to get a muscle biopsy. A vitamin deficiency panel would also be helpful. We know that she hasn't had any bariatric surgery, but we don't know any other risk factors. More importantly, it's a relatively benign test, and if her deficiency is addressed appropriately, then her symptoms can presumably be reversed. Further testing for infectious causes can also be helpful, whether it's a quantiferon or T-spot, HIV, and RPR as infectious diseases that we know can be great rheumatological mimickers. And that is it.
Okay, we will take questions for 1 minute before we have Dr. Hussain tell us what the patient had. Please put your questions in the Q&A box if you have any. Doesn't seem like anybody has any questions. Seems like everybody, okay, well, there came one. Was an echo done for her heart?
It was done later and it was all within normal limits.
So I guess everybody is excited to know what this patient had. Dr. Hussain, over to you.
Thank you, Dr. Gao. That was a very good breakdown of the case with great differentials and appropriate workup as laid down by you. So this patient ended up getting a skin biopsy, myositis panel, and we asked for her new symptoms that were headaches, fevers, lethargy, malaise, and left eye pain for a temporal artery biopsy. So she underwent a temporal artery biopsy as well. Her myositis panel was negative. Her skin biopsy, which was done from the right upper back, which showed skin with subtle interface changes, superficial perivascular lymphocytic dermatitis, and lymphocytic hidradenitis. In this section, there is a skin within which there is slight vacuolar change and pigmentary incontinence. Overall, the thought was that this could be atypical presentation, but dermatomyositis versus lupus should be considered for these findings. Next slide. Temporal artery biopsy was done. In her case, bilateral temporal artery biopsy was done, and the left temporal artery biopsy showed inflammatory infiltrate identified perivascularly and within the media, and these findings are read to be compatible with temporal arteritis. Next slide. So yeah, so I mean, we don't have to really focus on the differentials. A very nice list of differentials already been laid down by Dr. Gao in detail. Next slide. So we ended up diagnosing this patient with giant cell arteritis, more so with dermatomyositis. It was always in our thought process, but because of her variable examination limited by pain, her negative myositis panel, her negative, remarkably negative EMG, CK aldolase, we were more concerned for a positive temporal artery biopsy in her case with fevers of with high-grade fevers of unknown origin, headaches, left eye pain. So the next slide. So this is the slide that is showing that there is inflammatory infiltrate, macrophages, and lymphocytes going from the adventitia slightly into the media. Next slide, which is showing the same thing but in a more zoomed out view. Next slide. So the questions with this case that I had were atypical inflammatory changes on temporal artery biopsies, their significance and association with GCA, GCA presenting as fever of unknown origin, and how different it is with the typical GCA presentation. Classification criteria, as we all know, obviously is designed for research purposes. However, we often find ourselves to take some help to aid in reaching to a diagnosis from it. There are five criteria for GCA classification, and of those, three needs to be met. Age over 50, new onset headache, temporal artery abnormalities, elevated ESR over 50, abnormal biopsy. Next. So temporal artery biopsy is a hallmark for the diagnosis of giant cell arteritis and provides objective evidence of the disease, with inflammation involving the media being considered the most typical and characteristic histologic finding. Subtle anomalies, including inflammation limited to adventitia or periadventitial tissue, is more controversial. Next slide. Classic GCA on histology is defined as temporal artery biopsy showing mononuclear cell infiltrate with occasional giant cells involving the media or all vessels. However, in literature, we find a lot of subtle findings outside of media, which are seen in conjunction with the diagnosis of GCA. However, little is known about those findings and their clinical significance. These findings are classified as ILA, inflammation limited to adventitia, VVV, perivascular infiltrates within adventitia, a small vessel vasculitis with infiltrates of periadventitial vessel. Together, they account for almost 10% of the patients with clinically diagnosed GCA without classic medial wall inflammation. Next slide. This is a nice study done by Dr. Lee Pandu and his colleagues, where there are two pathologists who re-reviewed 100 first temporal artery biopsies to further describe the predictive and diagnostic value of these findings, of these subtle histologic findings. And together they found that 75 patients without classic finding features of GCA, 8 had GCA diagnosis. The predictive value for ILA, VVV, SVV by either and both pathologists were 17%, really low for VVV, 0%, and 7 and 10% respectively. Next slide. Next slide for the, it's just focusing on that. So this is a very big study, Italian study that was done over where they studied 888 temporal artery biopsies. And the purpose was to have a better understanding of different histologic findings on temporal artery biopsies and their clinical significance. Of those 888 biopsies, 354 patients actually were diagnosed with clinical GCA. Of those, 274 cases actually had the classic temporal artery biopsy findings involving the media. Of those, 7% had ILA, 6.5% had small VVV, and 9% had small vessel vasculitis. They further noticed that of those 322 patients that were included in the study, 317 patients actually carried the diagnosis of GCA. However, 5 had a different disease. 3 of those patients had SVV, small vessel vasculitis at histology, and 1 with SVV were diagnosed with amyloid deposit and 3 with ANGA associated. While 1 patient with a classic finding with media involvement had the diagnosis of polyarteritis nodosa on clinical grounds. Next slide. Yeah, this is just the breakdown of they further notice the different clinical and laboratory characteristics of those patients with different biopsy findings. And if you notice, they notice that the male predominance is more likely in patients with atypical finding or less of a difference in sex distribution in these patients. These patients with atypical kind of histologic features also are less likely to have cranial symptoms or typical abnormalities of temporal artery examination, jaw claudication, and are more likely to have a more robust ESR elevation. Yeah, next slide. So they concluded that these atypical findings should be included within the spectrum of positive temporal artery biopsies noted in patients with GCA. However, other rare kind of manifestations should also be considered. Polymyalgia, despite the difference in some clinical presentation, they noticed that polymyalgia rheumatica and blindness were equally represented in all these groups. Next slide. Yeah, so there's this study done by Dr. Alec Lyson and his colleagues to see how silent TA, which presents a little differently than more typical temporal arteritis or giant cell arteritis. So they studied about 175 patients who carried the diagnosis of giant cell arteritis and further distributed these patients into three categories of being silent, or based on their presentation, being silent, overt, or other clinical picture. Silent was the disease characterized by patients presenting with more constitutional symptoms like fever, malaise, elevated ESR of unknown reason, while patients with overt were considered those with typical 2 or more cranial symptoms like scalp tenderness, headache, visual symptoms, and jaw claudication, while other patients were characterized who had less than 2 typical cranial features. Next slide. Yeah, these are just the main clinical data. Next slide. And next slide. Yeah, so this is the slide that compares the patients with silent temporal arteritis while those with overt or typical cranial arteritis. And they notice that these patients, even though there is a delay in diagnosis with patients with silent temporal arteritis, these patients essentially they did not really develop any visual symptoms or visual loss, which was a little bit reassuring. However, they had a more robust elevation in inflammatory markers and more profound anemia and hypoalbuminemia. Next slide. Next slide. So take home points where there are histologic anomalies of GCA are present in as many as 10% of the patients with a positive temporal artery biopsies, lacking the typical findings. They are considered not pathognomic for GCA. There are conflicts in literature related whether these are within the spectrum of histologic changes concerning for GCA. Clinical correlation is required. In the absence of inflammation in media, other etiologies for abnormal temporal artery biopsies like ANCA-associated vasculitis, PAN, amyloidosis, infection, malignancies should be considered. However, in the correct clinical setting, diagnosis of GCA should not be overlooked. Once the diagnosis is established, the treatment should be really aggressive. And that should be, these are the references, and that's the end.
Thank you so much, Dr. Hussain, for such a great presentation. Very interesting case, and we are getting a few questions. So if you can go over those. One question about the skin biopsy. Did the skin biopsy show lymphocytic infiltration of muscle in GCA is one of the questions. Can you go over your slide for the skin biopsy, please?
Lymphocytic infiltration of muscle in GCA.
And it says, sorry, was referring to skin biopsy. So maybe something in the report?
Yeah, can we go back to slide number, I think it's 12 or 13. Yeah, slide, move forward. Next slide, next slide, next. Sorry, I can't see. Yes. So let me see. There is lymphocytic hidradenitis, but not, yeah. So they're saying there is slight vacuolar change and pigmentary incontinence at the interface, and a slight superficial deep and mid-dermal perivascular lymphocytic infiltrate without eosinophils or plasma cells. There is predominant periocrine inflammation, again consisting predominantly of lymphocytes. There may be an increase in interstitial mucin. The interface changes provide support to the clinical impression of dermatomyositis. And in addition, there are changes that could suggest the possibility of lupus, or perhaps might represent additional manifestations of dermatomyositis. So lymphocytic infiltrate is noted, but I'm not sure if it's going into the muscle.
Yeah, since it's a skin biopsy, I think maybe they were just referring to the skin biopsy having lymphocytic infiltrate. I hope that answers your question. The next question is, do you have an explanation for hand muscle atrophy?
We don't. That patient did not have any distal muscle weakness. She did have CMC OA changes and some like tenderness that point toward that, but not much explanation for the thenar atrophy.
Okay. The another question is, how did the patient respond to therapy, and what therapy did you try?
Yeah, so initially we started her on 1 mg per case of prednisone, and she and I saw her in clinic 1 week back. Her headaches completely resolved. Her fatigue was resolved. Even some ironically, her pain over her shins resolved. She was feeling better. I got repeat labs in 2 weeks. Her anemia was it was gone. Her hemoglobin was 13. Her ESR, her CRP, her inflammatory markers were within normal limits. She still have some elevation in alphos. Yes, this is an interesting question. How do you explain skin biopsy? And I may not have a very good answer. I try to do literature check and see if we see dermatomyositis causing temporal arthritis, and I didn't really see much of an evidence of that. She didn't really have any muscular findings. Her EMG was negative. She had no muscle weakness, proximal muscle weakness. Her muscle enzymes were within normal limits, and her myositis panel was negative, and her headaches, fevers of unknown origin, left eye pain, and all that. And with a positive temporal artery biopsy, we decided to focus on one inflammatory process at one point.
Now the question, sometimes GCA can be a harbinger of malignancy. Did any of atypical GCA patients have a higher incidence of malignancy?
Not in the literature, but I did. Obviously, this is a known fact that these patients are at high risk for malignancy. She had a very thorough workup. She saw hemonc as outpatient, and they did not feel that she needed a bone marrow biopsy and any further workup to really explore that idea.
Well, excellent case. And any other questions we'll take at the end of the presentation. Now we'll move on to our second case. Our second case is being presented by Dr. Mugdha Agarwal. She's a practicing rheumatologist at Arthritis, Rheumatic, and Back Disease Associates in New Jersey. She completed her residency at Yale and her rheumatology fellowship at University of Pennsylvania. And our discussant today for this case will be Dr. Mitali Sen. She completed her internal medicine residency in Einstein Medical Center, Philadelphia, and her rheumatology fellowship at Emory University, Atlanta. She joined as faculty in Einstein in July 2020. Dr. Agarwal.
Thank you for this opportunity. So I will go ahead and start my case. So this is a case of a mysterious skin lesion in a patient with inflammatory arthritis. Next. This is a 36-year-old Caucasian male with a recent history of undifferentiated inflammatory arthritis who presented in September of 2016 to the office for his routine follow-up of a rash over the dorsal surface of his right hand. He had initially presented to the rheumatology clinic in 2015, at which time he had a palsy articular inflammatory arthritis of some of the PIPs on his right hand. At that time, he had denied any skin rashes or symptoms of inflammatory bowel disease. Previously, he noted he did have right second digit swelling a couple months prior to the appointment in 2015. After we saw him in 2015, he initially did not respond to meloxicam or other NSAIDs and was finally put on prednisone, which helped him slightly. Over the course of next year, as he was followed, he was put on methotrexate and eventually adalimumab for inflammatory arthritis, to which he responded to pretty well. Prior to the initiation of biologics, he was also treated for latent tuberculosis exposure with isoniazid for 9 months. He had started the adalimumab after 6 weeks of treatment and clearance from infectious disease. He improved on the medication regimen and was off of the steroids at his prior appointment in June of 2016. In September of 2016, he presented with this unusual growth over the dorsum of his right hand. The visit right before that, he had a very mild rash and a small nodule in the same area. The patient was resumed on prednisone 20 milligrams with a taper prior to the September appointment in August of 2016 due to recurrence of PIP and MCP swelling in his right hand. A diagnostic test was done after his September visit. The medications at the time in September were adalimumab 40 milligrams every other week, methotrexate subcutaneous 15 milligrams per week, tramadol as needed, prednisone 20 milligrams once daily. His past medical history consisted of hemorrhoids. Family history was remarkable for hyperlipidemia and multiple sclerosis in his mom and hyperlipidemia in his father. He did not smoke alcohol, did not smoke cigarettes, occasional alcohol use, no illicit drug use. He did work as a zookeeper at the Philadelphia Zoo, and he was married without any children. His physical exam, so his vital signs were stable. Otherwise he appeared healthy. His respiratory and cardiovascular exams were unremarkable. In terms of his musculoskeletal exam, so he had full range of motion of his extremities with enlargement of his right third PIP and right third MCP joints. And there was an adjacent area with a large confluent erythematous nodule. Otherwise, his strength was preserved and there were no other rashes. The labs from August 2016, when he had initially presented with the smaller rash or the lesion, were largely unremarkable. His inflammatory markers were fine. His CPC and CMP were also okay. His labs from his initial visit in March of 2015, again, not much there. His Lyme was negative. Inflammatory markers were normal. Rheumatoid factor and ANA were negative, along with the TSH that was normal. In June of 2015, so kind of his second visit to the clinic, he had slightly elevated CRP. His CCP, HLA-B27, ACE were negative, along with his Hep B and Hep C antibodies. In November, he was found to have a positive PPD with a 20 millimeter in duration. In 2014, his PPD had been negative. His right hand x-ray had just shown some mild soft tissue swelling at the right second PIP, and his chest x-ray was negative as well. And this is the picture of the lesion which he presented with in September of 2016. And I will take any questions.
So, Dr. Agarwal, the first question was, is there a picture of the nodule, which you already showed? And if you don't mind going back to that picture while we are taking questions for the next 1 minute. What does he do at the zoo? Aquarium maintenance? Both the questions are about his zookeeping.
So I'm not exactly sure what he does at the zoo. I'm sorry.
Another question, was he already on TNF inhibitor when he developed the nodule?
He was already on a TNF inhibitor, yes. And he just worked with general animals. He didn't really have like a specific animal that he worked with at the zoo.
Okay, now we have Dr. Sen, who will work up this case.
Hi, good evening, everyone. I first of all appreciate all the organizers for having me today. Thanks, Dr. Agarwal. It was a very interesting case. I have to admit, I had some fun with the differentials here. So just to summarize what I was given at this point, so we had a young male with possibly a seronegative inflammatory arthritis who's on methotrexate, prednisone, and Humira. Obviously, his occupation as a zookeeper does bring up all the zoonotic differentials that I would add. And another interesting thing that I picked up was the mention of a positive PPD and treatment for presumed latent TB with isoniazid. So broadly at this point, I'm going to classify the differentials I thought of under infection, whether this was the skin lesion is a part of his underlying autoimmune disease, whether it's an adverse effect of one of the medications, and then just because we have to keep it always in the differential of malignancy. So moving on to the infections, given the clinical course, I'm not thinking very highly of like staph or strep because it seemed to be a little bit more indolent. So with especially his animal exposure, I want to bring up Bartonella, Mycobacterium, especially atypical Mycobacteria, because his PPD was slightly positive and he was presumably treated for latent Mycobacterium tuberculosis, if that is the case. Also anthrax, I just want to bring out these differentials. I'm not putting them in any order of possibility right now, but just with his history of animal exposure, anthrax, psittacosis, syphilis less likely, or just enodosum because of an underlying bacterial infection. Then within the fungal, sporotrichosis, histoplasma, coccidio, or paracoccidio were in the broader differentials of fungal etiologies. Next slide. So parasitic, obviously cutaneous leishmaniasis, less likely amoebiasis or giardiasis, but there are cutaneous manifestations with both. So that's why I did put that up here. And then a little bit less clinically for viral, but HIV or wart disease, HSV disease. Obviously, this was happening in 2015, 16. So I'm not going to say COVID-19, although maybe if it was happening earlier last year and we didn't know, I could have put that in the differentials, but doesn't seem like that right now. All right. Then I want to move on to my next differential, whether the skin lesion is just part of his evolving disease that we are now seeing. So whether this is all just chronic gouty arthropathy and now he has developed a tophi there. Not a very classic site, but I want to keep that in our differential. Again, not a classic site for rheumatoid nodule, but it is on the extensor surface, and with his history of inflammatory arthritis, that's another part of his evolution of his underlying disease. Sweet syndrome, whether this is cutaneous vasculitis, this is a nodular manifestation with PAN, just general enodosum. And then in my third differential, which was medication induced, which I think was brought up in our initial questions also. So he was on Humira, and TNFs can cause sort of a paradoxical reaction, paradoxically induced granulomatous disease or psoriatic disease, so TNF-induced granulomas, or just generally if it was sarcoid all along with the seronegative inflammatory arthritis, and then idiopathic nodular paniculatus. And then in my fourth differential of malignancy, before going to malignant nodules, just benign nodules, so unrelated but possibility of a lipoma, sebaceous cyst, xanthoma, a dermatofibroma, or a keloid, a pyogenic granuloma that's about to burst. Keratoacanthoma I put up there because it is on his sun-exposed skin. I'm going under the assumption that he works outside and will be sun-exposed, and it looked like a nodule with a central plug. And then I put up nodular prurigo. Not a very classic manifestation, but they can result from localized trauma or a localized animal bite. So that's why I put that in my list of benign nodules. And the next slide for malignancy, just to list out more common things that we could see in the hand: basal cell, squamous, malignant melanoma, Kaposi's, lymphoma, metastatic glomus or neurofibroma is the least likely according to me at this point. So in terms of the workup that I was given, we have a CBC that is essentially normal, a CMP that's essentially normal, and the inflammatory marker with a CRP of 4.1. Next slide. So just to mention, and we were given a X-ray of the hand that had shown some soft tissue swelling, but no bony changes. So in terms of workup, just to kind of work things from the infection standpoint, and to kind of get a sense of how extensive the disease involvement is, I'd like to get some serological testing for syphilis, leprosy, to get a sense of whether this could be reactivation of TB. I wanted to get a chest X-ray, a UA to screen for other organ manifestations. And I probably would have considered getting an MRI of the hand to see if there was bony involvement already, whether there was underlying osteomyelitis under that lesion. But I think what will really give us the diagnosis will be getting some tissue. So getting local cultures, getting cell count, getting stains for AFP and gram stains, cytologies, and probably sending into hand surgery for an excisional biopsy and a deeper culture to look for what's with the histopathological findings from that area, whether we're seeing granulomas, paniculitis, lymphocytic infiltrates, or we see signs of vasculitis. Next slide. So just laying out my top 3 differentials, my highest suspicion was for an atypical indolent infection, especially given that this is a patient that has had a more chronic development of a skin lesion, but he is somebody who is immunocompromised with all the DMARDs that he's been on. So atypical mycobacteria, especially with animal exposure, and the positive PPD in the past, or Bartonella. And for that, I mean, obviously we're gonna hold all the immunosuppressive medications at this point of time and figure out what infection it is, and then see if his joint symptoms ever return back. The second differential I had was whether this was a gouty tophi or a rheumatoid nodule. Third differential, whether it's a medication, TNF induced or a primary granulomatous process. That's it for me.
Great job with the differentials, Dr. Sen. We're going to take questions for 30 seconds before we give it to Dr. Agarwal again to find out what this patient had. I don't see any questions yet. Okay, to keep everybody on time, we're gonna ask Dr. Agarwal to break the suspense and tell us what this patient had.
Okay, so we referred the patient to infectious diseases and hand surgery. He had the removal of the hand lesion and the culture showed mycobacterial marinum. He was treated with rifampin and clarithromycin. His Humira, adalimumab, and methotrexate were stopped, and then his lesion resolved. He had no recurrence of his arthritis after the completion of his antibiotic therapy. He remains off of immunosuppression and is doing well. So I'll talk about the musculoskeletal manifestations of mycobacteria today. So next slide, please. So these are the most common organisms that cause mycobacterial infections. Obviously, tuberculosis is something we think of the most commonly. And then I would say mycobacterial marinum is also very common. Some others are M. penzasii, M. intracellulare, M. haemophilium, M. fortuitum, and M. abscesses, but those are, I would say, more rare. So what are the routes of infection? So for tuberculosis, it's mostly hematogenous spread to oligoarticular sites. For non-tuberculous mycobacteria, it's hematogenous spread, but that's mostly seen in immunocompromised hosts. There's contiguous or lymphatic spread, which is seen after percutaneous inoculation. There's traumatic inoculation with thorns and other things, which are usually done in soil or water, and presumably our patient maybe got his infection through this since he did work with animals. Animal bites, it could have been an animal bite as well for him. Non-sterile water and IV drug users can lead to hematogenous spread and lead to non-tuberculous mycobacterial infections. There's iatrogenic via steroid injection. So if sterile techniques are not used or the solution is contaminated, this can be seen. Surgeries involving prosthetic joints, and then medical tourism when people go out of the country for cosmetic procedures. Some risk factors that predispose people to these kinds of infections. So some genetic risk factors include mutations that interfere with interferon gamma and IL-12 production and signaling, STAT signaling. There's monomax syndrome, which is an autosomal dominant syndrome where patients present with monocytopenia, B and NK cell lymphopenia, and usually they present with opportunistic infections with bacteria, mycobacteria, viruses, fungi, things like that. It is a life-threatening syndrome and it's a precancerous disorder. Chronic granulomatous diseases also pose high risk for developing these infections. Some acquired immunodeficiencies such as autoantibodies against interferon gamma, and then iatrogenic immunosuppression with corticosteroids and TNF-alpha inhibitors are also risk factors for development of these infections. Other risk factors, so HIV or AIDS, malnutrition, malignancy, diabetes, renal disease, and advancing age. Clinical manifestations of TB infections. So these infections tend to be indolent over months to years usually, unlike bacterial infections, which are more acute. Septic arthritis is most commonly seen in the spine with tuberculosis and also in larger joints, but spine is more common. Small joints and extra-axial osteomyelitis is less common. Usually patients present with chronic joint effusions or synovitis, and infections can be seen up to 180 months after knee replacement surgery, which goes to show how sort of indolent these infections can be. With tuberculosis, bone erosions and cold abscesses can also be seen, especially in long-standing infections. And this is not pathognomonic, but Rice bodies, which I will talk about a little bit later, should also raise suspicion for tuberculous infections. So non-tuberculous mycobacterial infections tend to be a little bit more subacute to chronic septic arthritis. Vertebral osteomyelitis is less common than with tuberculosis. Tenosynovitis after traumatic inoculation can be seen in immunocompetent hosts, and subacute to chronic ulceronodular infections can develop over months to years. M. marinum is particularly known for nodular lymphangitis, which is basically a condition where patients develop suppurative inflammatory nodules along their lymphatic vessels. Up to 25% of M. marinum patients develop tenosynovitis. And chronic soft tissue infections can often extend to involve bones or joints. Erosions are not usually seen with this category of mycobacterial infections. So diagnosis, it can be probable or confirmed. Oftentimes with tuberculosis, the organism is isolated at a different site because it's a hematogenous spread most commonly. Absence of a positive PPD or an interferon gamma release assay should not exclude extrapulmonary TB. Microbiologic diagnosis becomes very, very important in non-tuberculous mycobacteria, especially given the heterogeneity of them and then differences in susceptibility to medications. Imaging can often help diagnose this as well. So what is in imaging that helps? So TB infections are usually characterized by peripherally located osseous erosion, especially long-standing infections. The joint space narrowing that develops is usually gradual compared to pyogenic infections. Pott's disease, which is what we think of with spinal TB mostly, has very distinct features that help us distinguish it from bacterial spinal osteomyelitis. So things that help are, so Pott's disease tends to have a multi-level involvement. There are large paraspinal abscesses which are seen with Pott's disease. There are presence of bone fragments, and it usually tends to spare disc space, unlike bacterial infections. X-rays are okay for later disease, especially since we do see erosions, but MRIs help diagnose early disease, and they can also help with soft tissue findings, and MRIs identify rice bodies. So this is a picture of a patient with, this is a knee of a patient with tuberculosis, septic arthritis from tuberculosis. And the white arrows show little small hypointense particles in the joint cavities, and those are rice bodies. So rice bodies basically signify chronic synovial inflammation. So this can also be seen with rheumatoid arthritis, but in the right clinical setting, this is seen with tuberculosis as well. And then this is an X-ray of a patient with septic arthritis from tuberculosis. And you can see that the patient has marginal erosions. That would also help. And now this is a patient with non-tuberculous mycobacteria. And as you can see, the left two pictures of the radiographs look pretty normal, but the right picture is of the MRI, and it shows inflammation of the flexor tendon of the ring finger. So microbiologic diagnosis becomes very, very important in these patients. If possible, a synovial aspiration should be done. White blood cell counts tend to be lower with mycobacteria compared to bacterial infections, so that can sometimes point you to one direction or the other, although that's not 100% reliable. AFB staining should be performed on the synovial fluid, although it's not a very high yield. So there was a review of 40 patients which showed that only 14% of tuberculous effusions were positive AFB stained, compared to 25% with non-tuberculous mycobacterial effusions which stained positive for AFB. So not a great yield. What really helps is getting a biopsy of the bone, the cartilage, synovium, or the abscess, and getting, if possible, a histologic examination. Especially in immunocompetent patients, we can often see necrotizing or non-necrotizing granulomas, which can help. And then AFB staining should also be done on the biopsy. Microscopic examination is often not very helpful, as it's really hard sometimes to isolate the offending organism on just microscopic examination. So it's very, very important to do culture of the infected tissue, and culture remains the gold standard for diagnosing mycobacterial infections. Given that these infections are often disseminated, it is helpful to think about sampling other areas as well, such as blood, urine, lymph nodes, just to increase the yield. Oh, next slide. Early and effective antimicrobial therapy is obviously the mainstay of treatment. With non-tuberculous mycobacterial infections, surgical and medical management is often required, as was with our patient as well. Thank you. And I will take questions now.
So if anybody has questions, please feel free to put it in the chat, the Q&A chat box. Very interesting case, Dr. Agarwal.
Thank you. I just want to add something afterwards. When we were talking to the patient, we did find that he had a fish tank at home. So I don't know if that was the source.
The question is, was his original arthritis due to TB?
So I have thought about this, and I think it was. And the reason is because after he got treated, he did not have recurrence of his arthritis. We didn't have to put him back on any meds. So I think it was because of his infection.
Next question is, did the lesion resolve with treatment?
The lesion did resolve with treatment. I didn't have a picture when I was presenting the slides, but I was able to get a picture later on. So it's not in the slides, but I can maybe like put my phone up. I don't know if anyone can see, but it did. it did resolve after.
Seems like that's all the questions we had. Well, thank you so much for all the attendees and participants for today's conference. Thank you to all the speakers for such wonderful cases and presentations. I would also like to thank the Philadelphia Rheumatism Society and the pharmaceutical sponsors today for hosting an event. Hope to meet you all in person next time, and have a good night, guys. Thank you so much.